Hello, Bob Ravenscroft here, the Vice President for Advancement at Bryan Health. Today I have Dr. Jim Nora with us. He's back by popular demand to talk about monoclonal antibodies, and we'll cover some more ground. Go ahead and pull up the first slide, Jeff. It continues to be a very trying time here at us. 49 represents the number of people who have passed away since August 9th when, at least that's kind of where I think our fourth wave started to get real serious. So these deaths are happening from patients who are young and old, male and female. Some are, coming in with some compromising issues. Some are coming in previously very healthy. Overall, the trend line, if people watch those, is stabilizing a bit. We don't know if that is reason for optimism. We'll take it at this point, but it's yet to be seen. But what it is still revealing is there is one common denominator. It is the unvaccinated population that is driving our inpatient care. It's costly. It's delaying care for other non-COVID things, ability to accept transfers, and that's all very well documented in national and local reporting. So in the following slides, here's what we're dealing with right now at Bryan. At midnight, we had 71 patients hospitalized for COVID-19, and as you can see, only 10 of them were vaccinated. When you go to the ICU levels of care and patients on ventilators, this has been a constant for, several weeks running that the patients in our ICU and on ventilators are all unvaccinated. You can see it's spanning the ages. It's got a nice little traditional bar chart there. Dr. Nora might be able to elaborate on this, but the older patients is where we're seeing some vaccination breakthroughs requiring hospitalization yet. But you can see there are some very young people in there, and heck, when you're my age, if you're in that middle bar of 50 to 64, I still consider that young. And then it was kind of alluded to on the opening slide. On patients on ventilators, they are exclusively unvaccinated at this point, and you can see we have, by my criteria, all very young patients struggling with this. We remain very full. At midnight, we had 552 patients here at Bryan Medical Center receiving some level of care. And I think where the weariness and frustration lies is that at a hospital like ours, we're the last line of defense in this pandemic. With that, we are so thankful for the people in Lancaster County who have gotten vaccinated at higher rates and adhering to the different layered protections, like beyond the vaccination, some distancing and masking that's in place here. And I think we'd be in a pretty crippling situation if we did not have the cooperation from the residents of Lancaster County. So a big thank you to all of you. And where this is really important, when you're looking at our COVID inpatient numbers, 38% are now from outside of Lancaster County. You put that all together, and the vaccination rates here in Lancaster County are so helpful for us. One last thing. I say all that, there's still some room for improvement. If you have not yet got the COVID-19 vaccine, it's very easy to do. It remains free. You can text your zip code to that. You can call that number. Or you can go to vaccines.gov and find out where you can get your vaccination. Before we turn to some information on monoclonals, I also just want to thank the community. The outpouring of support is tremendous. Yes, there's some frustration. Yes, we're tired and we're weary, but we also know that there are far more people that are trying to be part of the solution than not, and they're doing everything they can to pick us up. So just real quickly, I got this report from our team just a day or two ago, and here's some of the things that this community continues to do for us, from food coupons to signs to other acts of encouragement. You have Park Middle School, Ollie, Sheridan Lutheran, Heartland Speech and Occupational Therapy, the Lincoln General Class of 1967, Lincoln Friends and Optimist Club. Then in the pipeline for things coming in coming weeks, you have St. Mark's Methodist Church, Lincoln Berean Church, the Waverly First United Methodist Church, A meal train has been developed by just members of the community for members of our ICU and ED that work on the weekends. And then even Spreetel is planning some things for the week of October 4th. This stuff is all incredibly, incredibly meaningful and uplifting to our team. So we thank you very, very much. Okay, I'm going to go over some high-level stuff on some monoclonal information before we turn it over to Dr. Nora, and then we'll be available to answer your questions on any related topic. The treatment using this began at Bryan on September 8th. As you can see from the slide, we've treated about 70 patients to date. There's a couple of different monoclonals. This is where Dr. Nora will come in handy. Right now we have the Regeneron monoclonal, and it's important for people listening to know and to share. This does require a physician's order to be admitted into the monoclonal clinic, and then there's some criteria in place as well. If a person does not have a primary care physician, they can go to urgent cares. Most of our communication right now is going to physicians and referring physicians so they can get you lined up for this clinic. It's important to know that the supply is limited. It's almost like deja vu to the early days of the pandemic when we were struggling to get test supplies and other personal protective equipment, that there's not a lot of this out there. Obviously, the Regeneron, that's probably a familiar one. Back in October, a pretty prominent person received that. But much like other supplies early in the pandemic, this is on what is called a state allocation. So that is where it's being determined on where different monoclonals go. We are scheduled to get 96 vials in our next allotment. That's why it makes, having this criteria in place on who can qualify for it pretty important so we can manage this and get it to the people who need it most. Some of that criteria, and it's certainly not all of it, but it will require a positive PCR or antigen test, and it has to be done within a certain time frame of symptom onset to be effective. Again, Dr. Nora can shed some light on that. There is an opportunity potentially to prescribe this to people that have had extended contact with someone who's COVID positive in a close duration. This is where criteria and supply, we're totally dependent on that. And then there's also considerations in there for people who would be unlikely to have an adequate immune response for something else they have going on. What patients can expect real quickly, it's either through an IV or an injection. You can plan on being there for about an hour and a half if you're one of the patients that need that for a 1 hour observation time after that. And unfortunately for this clinic, there is no, we really can't have patients having visitors in there with them for that hour and a half unless the patient receiving it is a minor. So if you feel you need this treatment, if you're not feeling good at all and you have a positive test, it's important to see your doctor as soon as possible, and to, if you don't have a physician, again, go to urgent care. You can learn more details by going to that website. On our website, you can see what it is there to learn more. But with that, Dr. Nora, I'm going to call him up to talk about this and then a few other things like flu shot and some other infectious disease things that are also compromising hospital capacity at this current time. So Dr. Nora, and then we are again here to answer any of your questions. Thanks.
Thanks for the opportunity to speak today. We are really lucky and excited to have this monoclonal antibody clinic up and running. It is so important to have treatment options for patients in the outpatient setting. While we are rounding in the hospital, I can tell you that we see a number of patients and realize, wow, if this patient had gotten a monoclonal antibody, they might not be in the hospital. And there are criteria that have to be met. And so it's always unfortunate when you see somebody in the ICU on the ventilator and realize, well, this person would have met criteria for getting the monoclonal antibody, and they didn't, and now they're in the hospital. That doesn't mean monoclonal antibodies will prevent every individual from getting admitted or being hospitalized. But whatever we can do to prevent hospitalizations and especially to prevent serious illness, we definitely want to do that. So, a couple of thoughts about who should get monoclonal antibodies, and there's some very specific criteria that are laid out. In general, we would love to offer monoclonal antibodies to anybody who has had illness that has onset within the last 10 days and has has risk factors for more serious illness. And the risk factors can include just being over 65, having a BMI greater than 25, so that it just means the tiniest bit, a little bit overweight, and of course anybody who's pregnant. Right now, how do we prioritize that? What I would say is if you've had a recent exposure and have any concern that you have a risk factor for more severe disease, just go visit with your doctor or go to urgent care and have that person make an evaluation and make a referral. In the setting where we have limited resources, what are the top priority groups? And those would include anyone over 65. If you have a new case of COVID and you're over 65 and you have not been vaccinated, this is what you need to get. And then another group is pregnant women. So we have seen, unfortunately, multiple deaths in the hospital of women who are pregnant. That should not happen. So if there's a woman who is pregnant and has not been vaccinated, she should get signed up for the vaccine today. Make the call, go to whatever clinic is needed, go to the drugstore, get the vaccine. If a pregnant woman is diagnosed with COVID-19 and has not been vaccinated, she should absolutely be a priority for getting this monoclonal antibody. Anybody over the age of 50 with risk factors, and then finally going down to age over 18 with risk factors. So please do not hesitate to reach out to your provider, urgent care. We want to do whatever we can to get people to have access to this monoclonal antibody. And we even have the opportunity to give it for post-exposure prophylaxis. So what I was talking about before is really for somebody who has acute illness, but if you have had a significant exposure to somebody who has had COVID-19 and you have not been vaccinated, you also are potentially eligible to get the post-exposure prophylaxis in the form of monoclonal antibodies. Couple other things to keep in mind. Our hospital capacity is, again, really getting to the breaking point, and we have lots of folks in the ICU on the ventilators. Many of these individuals have COVID-19, and once a patient with COVID-19 goes on the ventilator, they often stay on the ventilator for a prolonged period, and we've all seen patients that have been in the hospital for months with this. So it really, really makes it hard to have space for patients who have other needs, and those needs will continue to be there. Just because there's a pandemic doesn't mean that people don't have other medical problems and need access to the hospital. A couple things to keep in mind this time of year. We are about to enter flu season, and many may be aware that last year there really wasn't much of a flu season. And that's great, and we all think that may be due to the mask. People were masking last year, and that prevented a lot of the spike that we normally see in flu season. Please keep in mind that when we do have a flu season, we also see a spike of inpatient admissions. It's not nearly as big as what we see with a COVID spike, but we do see that spike nonetheless. So even if we don't have a flu season, I would strongly encourage everyone who is eligible to get the flu vaccine this year. If we have a whole bunch of people who are not vaccinated against the flu, that will only increase the stress on the hospital system and put members of the community at risk. Finally, we are really in the middle of mosquito season. So we have in Nebraska been a constant site for West Nile transmission since West Nile came to North America in the early 2000s. And last year we didn't have much of a West Nile season. Right now, the number of cases statewide it has already exceeded the number of cases last year. And I bring this up because rounding in the hospital, I have seen a number of patients that are suspicious for West Nile. So patients who get admitted with West Nile often take up a lot of resources. They end up staying in the hospital for quite some time. So my plea to individuals is, with mosquitoes being active, please think about wearing protective clothing in the evening, using the mosquito repellent, doing what you can to avoid mosquito bites, at least for the next couple months until we have a good hard freeze. That will also help to minimize admissions that could be related to West Nile and help to keep your hospital capacity where it needs to be. So with that, I will stop and turn things back over to Bob. Thanks.
Okay. Thanks, Dr. Nora. Okay, the first question. Can you discuss the efficacy of the governor's transfer call center? Does Bryan Health see that it is helping to ease hospital capacity? Well, to be rather frank, I don't think it's working out as well as intended. The previous time it was opened, it was kind of managed by CHI, actually right over in St. Elizabeth's, and now it's being handled by Naomi, the company that was behind Test Nebraska. And there are some issues. So what I have here is 5-6 pages of single line spacing text that is members of the media that came in on the tour last fall saw what we do, for our daily pandemic calls. Those have been restarted, and this section here is all about the transfer center. The ability for them to transfer unstable patients is not there. So basically, you are still having smaller hospitals throughout the region calling directly, trying to get transfers. So they might have some role, but they're not being helpful in the transferring of and finding a home for unstable patients, which obviously many of the COVID patients or the type of transfers that happen to a tertiary center like Bryan are typically unstable in one capacity or another. So hopefully some work's being done on there. Obviously, by evidence of the discussion it received on our pandemic call, that's happening as hospitals coordinate in the state and try to work through this. And I know that information is going back to the government officials to try to help get some relief and some more effectiveness out of it. Do you have anything in there?
I think that's a great summary.
Okay. All right. If someone is vaccinated, are they allowed to get monoclonal treatment?
So there are certain circumstances when that is allowed. In general, those that are vaccinated don't have to worry about going on to develop severe disease. However, persons who have underlying immunodeficiency, take certain medications that reduce the immune system's response, those individuals are still eligible to get monoclonal antibodies, and I would encourage them to do so.
Are you seeing more patients with long-term COVID stays, for example, remaining in the ICU on ventilators long after testing negative, more than early surges? I'm not so sure if it's more than early surges, but do you have that off the top of your head? I'll pull something up on my phone that might shed some light on that, but I
don't think it's my census, it's not that much different than the original surges. We definitely do see patients who have gone past their 20 days of inpatient isolation for active COVID and are no longer considered infectious, and yet they're still on the ventilator and remain in the units. That was true then, and that is certainly true now. I don't get a sense that that percentage has changed a whole lot. It was a problem then, and it continues to be a problem now.
Yeah, so it scrolled up, so I'm not sure who asked the question, but we today have 22 patients that are still hospitalized as inpatients, 22 that are past their COVID infectious time. Of those 22, 10 of them are in the ICU and 9 of them are ventilated. So, yeah, it's still impacting us. In case a patient gets a referral, how do they prepare for the treatment and what are the side effects?
So I don't think there's any particular preparation that needs to be made. And certainly at the time of the referral, they'll give some specific instructions, but there really aren't a lot of side effects. It's simply an IV infusion in the case of treatment. So you would go to the infusion center, a nurse would place a small IV, and then the infusion runs over 30 minutes. Anytime there's an IV medication administered, there can sometimes be reactions related to the IV site. That's very rare, but that can happen. The monoclonal antibodies are very well tolerated. They don't tend to cause any long-term side effects. If you are getting monoclonal antibody related to post-exposure prophylaxis, then the preferred route of administration is actually subcutaneous. So instead of having an IV placed and an IV infusion, instead it's a small injection just under the skin.
Dr. Nora, are we still using convalescent plasma treatments?
No, we are no longer using convalescent plasma at this time unless it's in a research setting.
Okay, what are you seeing as far as testing recently? How has it been trending? Any recent testing data? I appreciate that question greatly, Bailey, because what the pandemic has changed where early on when we were setting up our drive-through testing and we're one of the only testing options, obviously everyone knows different testing locations were set up. I don't have hard numbers for you, but we can see if we can get something and follow up with you personally. What we do know is more and more people are coming straight to the emergency department to get their test. And I don't know if that's because there aren't as many testing options in the community. And we really encourage people not to be doing that. Because one, it puts a real crimp on the type of test that we need to do to get a very quick confirmed diagnosis to admit them to the hospital. So it is creating some pressure. And then one of the areas I work close with is our volunteer and customer care department. They're the people that man the front desk. And we are having people show up at the front door of our medical centers seeking testing. And obviously, we do what we can do to accommodate that, but we really encourage people to use the other testing options in the community. The ones in the emergency department are for those emergent, admissions that occur. So again, Bailey, I'll see if we can get you something a little bit more granular on that. In general, we're seeing a different type of demand for testing right now. I believe you indicated 70 patients have been treated so far, and there are 96 vials in your next allotment. How many are available now? I'm not sure where we sit now. We have a full clinic today. I know that the 96 on yesterday's kind of big call, that will give us enough for about, if we keep going at the same rate, at about for about 1.5 weeks. And then this allotment occurs weekly from the state, so we won't know what our next allotment is. Bryan has been transferring some general care stable patients to Crete to open space. Do you anticipate continuing to do that while patient numbers are high? And do you know if other hospitals are doing something similar? I would imagine it's probably unfair for me to comment on other systems, but I would imagine that's occurring, Matt. And it's kind of like a whack-a-mole game that it's dependent upon capacity at a given time based on what's coming in. And it's great that we have Crete Area Medical Center right down the road to take some of the general care. I would imagine we are in a period of time where that will continue as needed. You have anything more on the different transfers that are happening?
No, I think it's this is something that is addressed on basically a daily basis, and it always depends on the particular patients involved and the capabilities of any particular medical center. But I think the bottom line is that hospitals across the state are doing whatever they can to try and get patients to safe settings so that we can maximize capacity for COVID patients, ventilated patients, ICU patients.
You know, it made me think of it's a conversation that occurred in the hallway today. One thing we're really watching is what's going on in greater Nebraska. Again, up to 38% of our patients are now coming from outside of Lancaster County. And one of our cardiologists that, they clinic all over the state, and in some greater Nebraska clinics, the positivity rate is really, really high there. Again, we don't have great visibility to all the testing that's going on in rural counties now, but that's kind of a barometer for us is when physicians come back, they can bring back some kind of reconnaissance of what's going on out there with the absence of real data out there. Has Bryan lost any employees due to vaccination requirements? Yeah, we responded to someone, it was either Thursday or Friday of last week, and we have 5,518 employees currently, and 6 employees have chosen to leave the organization over the requirement. Do you worry that we will get to a point where all area hospitals are at capacity and there are little to no beds left? I think we're at that point. That's why we're speaking to you today and continue to put stuff out to the media every day and social media. And every hospital's in a different situation, and I would encourage you to speak to them directly. At Bryan, we are at a physical capacity limit. There's other places where there might be a little bit of physical capacity, but there aren't staff to fully staff those facilities, and that's sporadic all over the state. So we are maxed out as a healthcare system in Nebraska for all intent purposes. I know you sit on a lot of different calls. The ID physicians are coming out saying things. Is there anything you can add to the overall capacity?
I think we are definitely kind of at capacity. We've really been really beyond what the comfortable capacity has been for several weeks now. And I think that the next concern is, do we have to go into what's termed crisis capacity? It has different terms in different states, but where we have to make decisions that nobody wants to make about triaging healthcare resources, who doesn't get treated, who does get treated. Those are things we don't want to have to do, and that's why it's so important to keep our capacity. And again, the best treatment for COVID is prevention. So if anyone who has not had a vaccine, please consider getting the vaccine as soon as possible. That is the single best option we have at this point.
Thanks for the question, Alyssa. That's why I threw out early in the first waves of the pandemic, we always reported our daily census to kind of track that. It hasn't been a staple of our recent press releases, but that's why I shared it today. And I think the last time we spoke, we talked about, we're operating pretty full, but at a very highly efficient level when we're between, 520, 530, maybe 540 patients. That's what our system or our main medical center here in Lincoln is built for. And today we are at 553 and have been, above that threshold above the 540 threshold more days than not for the past month. And that just, not to belabor it, but that's what makes it so trying and tiring for our staff. We're trying to do everything we possibly can to meet the needs of the community. Unfortunately, that meant we had to eliminate some of the elective procedures that could be delayed for 30 days. So the cost that is going into COVID care at places like Bryan and across the country, and in fact, there were some recent articles on a national scale. We're talking in the billions of dollars now that this is beginning to impact, the healthcare system and essentially all of us. And those things are very real here as well. So when you combine the enormous everyday needs that people of this region expect of Bryan, and then you throw in, 70 plus, COVID patients who are here for extended stays, all of the testing requirements and so forth, it is very, very costly. And it's uncomfortable for us and anybody who works here to continuously be above that 540, daily census. It's very, very taxing and trying.
Yeah, one way to think about it too is maybe a summer heat wave, and if you have one day when the temperature reaches 105 or 110 degrees, that's not so bad if the temperature the next day is 85. But what really gets to be trying is when you have day after day after day of 100, 105, hard on humans, hard on animals, hard on crops. All of that is made worse by just the prolonged period of bad weather, hot temperatures. It's the same thing with COVID. We can definitely handle a brief surge that pushes our capacity, pushes our staff to their limits, but it's when that goes on day after day after day and there doesn't seem to be an end in sight, that's when we really get into trouble.
Okay, looks like questions are coming down to a trickle. Jeff, is it possible to pull up the vaccination slide again? Just like to close by thanking everybody who chose to get vaccinated. It's still available. It's still free. It's safe. It's effective. And I encourage you to, if you have not yet or people who haven't, again, it is so easy to do. And we're imploring people to do it. Again, this is the first line of defense, getting vaccinated. The monoclonals and what we're doing on a daily basis, day after day after day, is the absolute last line of defense for these patients. So it's right there for everyone. Please consider getting vaccinated if you have not yet. With that, we'll try to get some questions, more granular information to you, Bailey. And if anybody from members of the media have additional questions, you know how to reach us through, Brad or Edgar or Deb. And we'll do our best to answer your questions. Thank you.